All right, today we're going to talk about the physiology of making urine. So within that is going to be the ductwork, the anatomy of that, the physiology of how urine is filtered, excreted, and then some of the diseases. So ductwork and vascular supply. These are some of the anatomical structures of the kidney, starting with the renal cortex, that's at the very outer spots of the kidney. Notice those are very vulnerable to any types of trauma. And then the renal medulla, it's just below the cortex, the pyramids, the renal pelvis, and the renal pelvis shown in 4 here is this main big area of ductwork. And that's an area where stones can collect and form. And if a massive stone forms right there, it's called a staghorn calculus, because it'll take the shape of this whole pelvis. So it'll look like the antlers. And then, of course, the renal arteries shown in red, number 5, and the veins taking blood away from the kidneys. Which structure is feeding the kidney information about things like blood oxygen content, systemic blood pressure, and electrolyte status? This is a review from the last lecture. The answer is it's your aorta. The aorta, the renal artery, feeding all that information to the kidneys. And with that information, the kidneys, as secondary endocrine organs, release the hormones calcitonin, renin, and erythropoietin. So the business side of the kidneys is shown here, the nephrons, the renal cortex. Notice how the renal cortex has a massive amount going on. There's the glomerulus, the proximal loop, and then the loop of Henle. This loop dives down into the renal pyramid, then comes back out again to do more work in the renal cortex as the distal tubules. Then finally, notice how in between all of the nephrons is this collecting duct. So you have all these renal pyramids throughout your kidneys. So you've heard the term nephron. What structures make up the nephron? Is it the glomerulus, the proximal convoluted tubule, nephron loop, or that's also called the loop of Henle, and the distal convoluted tubule, or all of these structures, including this collecting duct? The answer is it's up until you get to the collecting duct. All of that counts as the nephron. So here is image of the nephron showing the glomerular capsule and these tubules. And now that we've gone through the anatomy of the nephron, we're going to go through what is happening, the physiology of what is happening within the kidneys. The nephron, the very first structure is that glomerulus. And that's the area where all the particles are being, well, all the small particles are being pushed out. And the second part is that ductwork. And that ductwork is surrounded by all these little capillaries. And all these capillaries are working to retrieve anything that got pushed out that they find important to bring back, like glucose, for instance. And then the distal part of that, they start excreting things like hydrogen ions to balance out the acid-base balance in the blood. So basically, they're taking back everything but the trash and get rid of all your toxins. Next question, where is urine most dilute? A, proximal convoluted tubule. B, the loop of Henle or the nephron loop. Or C, the distal convoluted tubule. The answer is A, right there after it leaves the glomerulus. So these are the ducts shown here. The glomerulus sits right here at the beginning, right here. And this is the path of the urine flowing through the nephron. So right at the beginning, everything is pretty dilute, as shown here in the lighter yellow. And then when it starts getting to the distal convoluted tubule, it's taken back. Sodium, water, amino acids. And then when it gets there, it's more concentrated. So we have these three major things that are going on. The filtration, number one, happening at the glomerular level. The reabsorption and secretion by these tubules, proximal and distal tubules. And then finally the excretion, which is micturition, or is the medical term, or urination. So the glomerulus has incredibly interesting cells. It has these podocytes. Podo means feet, so foot cells, cytes is cells. These foot cells surround this capillary bed within this glomerular capsule. And that allows only so much filtration to come through. So they're trying to restrict the particle size. And particle size would include things like cells, like red blood cells. So you don't want to be excreting out all your red blood cells at this point. The other thing about this glomerulus is that it's got arteries on either side, arterioles. So there's no exchange of oxygen happening here at this capillary bed, only filtration. So I put this sieve or this colander showing you how it has all these little holes surrounded by podocytes. And the first arteriole that comes into the glomerular capsule is larger. And then the second one is smaller, the smaller efferent arteriole, the blood leaving the arteriole, the blood leaving the glomerular capsule is smaller. And having a system where one is larger than the other forces more fluid, more plasma to leave the glomerulus. So it creates this pressure gradient. Now the homeostasis depends on the diameter of these afferent and efferent arterioles. Prostaglandins are chemicals that vasodilate that. So with prostaglandins, you have more blood flow going to the glomerulus. Angiotensin II is a vasoconstrictor. And so it shuts down or closes down the efferents. And that when it does that, it allows more filtration. And GFR stands for glomerular filtration rate. And notice how prostaglandins, since they vasodilate, this is where taking antiprostaglandins like Motrin and Aleve can become a problem. And we're going to talk about that in a few slides, about how antiprostaglandins, Aleve, Motrin, in too much quantities can actually create renal failure. Next question. Your uncle quit taking his blood pressure medications. His blood pressure is now 210/120. How will his urine change? Will it become more concentrated, or will he start seeing red blood cells in the urine? So the answer is you're going to start seeing hematuria, which is the same name for blood cells in the urine. With this really high pressure on the afferent arteriole, the pressure can overwhelm the podocytes and red blood cells can start leaking into the urine. So examples of that are hypertensive crisis or blunt trauma. You've had trauma to your kidneys. You see bleeding in your urine. Other things that you can see in the urine that's abnormal are white blood cells. And the term for that is pyuria. Protein in the urine is proteinuria. And protein in the urine can be signs of eclampsia, which is a problem during pregnancy, diabetes, or diabetes that's poorly controlled, and also infection where everything is inflamed. Okay, so let's go from the glomerulus to these proximal and distal tubules, where everything starts to get balanced out. The first part is that proximal convoluted tubule. Notice it's the most dilute part, and this is the part where things start being taken back. Water, sodium, glucose, amino acids, they get taken back into the capillaries that are surrounding the proximal tubule. And then in the distal tubule, things start coming from the blood. This is where you start sending out your toxins, medications that you've taken, and the excess hydrogen ions. So this is what makes your urine acidic relative to your plasma. So this is your acid-base balance. So this is why treating a urinary infection, if the bacteria is sensitive to the antibiotics, it makes it pretty easy to treat a urinary tract infection because it all concentrates in the urine, all the antibiotics. So this is the nephron, showing the big particles being filtered through that colander at the glomerulus. And then the proximal tubule getting your swag back. And I just move these words around to make the word swag, or sodium, water, amino acids, and glucose. And then the distal convoluted tubule is where you're tossing them out anything that's unwanted is getting tossed out. So that's your toxins, hydrogen ions, excess water, and medications. And the acronym I put for that is THEM. So squeeze out big particles, get your swag, and then toss them out. All right, so that is physiology in a nutshell. So let's go on to just a little bit of pathology, things that can go wrong. Urinary tract infections. I want to talk about those because they're like the leading cause of death in the elderly. As a matter of fact, this is how my mother died in the very, very end. They get this infection, it moves its way up into the kidneys, and when it moves into the kidneys, it becomes pyelonephritis. A kidney infection is pyelonephritis. A bladder infection is cystitis. And remember, in the kidneys, there's this massive vascular supply, these tiny little capillaries. And so anytime a massive amount of bacteria gets into the kidneys, it's easy to get into the bloodstream and cause bacteremia. Bacteremia is blood into the bacteria into the blood. And then sepsis is when you have an overwhelming bacteria that goes throughout your entire bloodstream. Let's do a case scenario. A medical intern in July, person who's very inefficient at getting their work done. So they're chronically dehydrated, they're not drinking water, and eating red Twizzlers from the commissary, this is the VA hospital, and bologna sandwiches from the VA cafeteria. And if you haven't guessed already, this person is me, many years ago. So the presentation is right-sided back pain, fever, go to the hospital, get a white count, very high of 12,000. There's bacteria in the urine, and admitted to the hospital for intravenous antibiotics. Which part of the urinary system is primarily affected? With a high fever, back pain, and I hope you'll answer kidneys. And that is why it's so important to get treatment very quickly, IV antibiotics, to make sure that that's treated. Pyelonephritis, infection in the kidneys. Remember, direct access to the blood, and sepsis, overwhelming infection in the bloodstream. Whenever you see someone that has persistent kidney infections, you need to start worrying about things like bladder stones. And usually, if someone is well hydrated, all the bacteria gets flushed away. But with chronic dehydration, stones can form and bacteria can form on the stones. So in my story, what had happened was the chronic dehydration indeed had caused kidney stones. And I did pass those kidney stones very painfully. And then since that period of time, there's been no dehydration, so a good amount of fluid intake, and no more kidney stones or kidney infections. All right, so let's go on to reduced urine output. It's one of the major things that's monitored in hospitals for patients that are ill. It's a sign of either dehydration, a sign of low blood pressure or a loss of functioning nephrons. In any case, it's a way to monitor how the rest of the vital organs are doing. So if the urine output is low to the kidneys, by definition, you're going to be getting low oxygen, blood flow to the other vital organs. Now, renal failure. Let's go on to a little bit of kidney failure, some of the causes and the treatment for kidney failure. There are two leading causes of kidney failure. First is hypertension, and the second is diabetes. So in uncontrolled diabetes, you'll start seeing a lot of kidney damage. Then you start seeing the protein in the urine and the destruction of the glomerulus. So persistently high elevated levels of glucose start to destroy small vessels. And the small vessels it destroys are important ones like the coronary arteries, small vessel disease, coronary artery disease, and also these small vessels in the glomerulus. So that's why you start seeing renal failure with uncontrolled diabetes. The other, uncontrolled hypertension, kidney damage. So with high afferent arterial pressures, you get hyperfiltration. It damages the endothelium of these small capillaries and arterioles. And those podocytes, the little cells that surround the vessels, get widened, and then you start getting this scarring. Another cause for renal failure, and sometimes this acute tubular necrosis is reversible. And this is in a patient that's had severe trauma, shock, where the blood pressure falls below its ability to autoregulate, and then the lack of oxygen to the kidneys and the nephrons is reduced, and they start killing off some of the tubules. So that's why it's called acute tubular necrosis. All right, another reason for losing kidneys. This is an actual patient I took care of. This is not him. This is a picture from the internet. However, so this was a case of a 35-year-old man who got drunk and he fell asleep in a bathtub with his arm hanging over the bathtub edge. So he lies in one position for long, long periods of time because he's essentially comatose. And he has a lot of pressure on these large muscle groups from the hard surface of the bathtub. He was admitted to the hospital in kidney failure, and his urine was this brown, and that's myoglobin. Those are breakdown products from muscle. When muscles get destroyed, it's called rhabdomyolysis, and the myoglobin goes through the kidneys, and the kidneys get overwhelmed, and it knocks out the kidneys. In some cases, this is reversible, but if it's overwhelming and it's gone on too long, then it's complete kidney failure. Another reason for kidney failure is too much pain medication that I referred to earlier. So I am for, here, take some Afferent. So renal failure in athletes. We had a nephrologist, actually a renal transplant surgeon, who trained in New York City. And the patients that he saw most in renal failure were the ballerinas. And because of the chronic pain, the toes, the damage to the feet, have a chronic overuse of these non-steroidal anti-inflammatory drugs. All of the ones that are in that class include Advil, Aleve, Motrin, naproxen, any of those. And because they are anti-inflammatory, non-steroidal anti-inflammatory antiprostaglandins, they will hit that first part, the afferent arterioles. So when these prostaglandins get blocked, it reduces the blood flow that goes to the nephron, specifically the glomerulus. So the nonsteroidals prevent vasodilation of the afferent arterioles. And so overuse can cause death of the glomeruli. So in summary, the urinary system, we talked about the physiology of making urine, how we have the filtration in the glomerulus, excretion and secretion, and then we talked about several types of diseases. So the main point is in the hospital, monitoring kidney function at monitoring the urine output is a great way to monitor all the vital organs. Any questions, please leave comments, subscribe to the channel.